Good morning, everybody. Welcome to the Friday Informatics Power Talk seminar series. Just so you know, today's actually the last seminar of the series because after that we have finals and then the end of the term. So a nice grand finish to that. So I'm happy to welcome Dr. Suresh Bhavnani. He is Director of Discovery and Innovation through Visual Analytics and Professor of Biomedical Informatics and Senior Fellow in the Steele Center of Aging. In the department, he's with the Department of Biostatistics and Data Science and the School of Public and Population Health at University of Texas Medical Branch at the University of Texas Health Science Center in Houston. He's a professor and he has much experience. He's a senior fellow of the Steele Center and a fellow of the American Medical Informatics Association. He obtained his Ph.D. in computational design and human-computer interaction from Carnegie Mellon University. And he's also previously on faculty at the University of Michigan. He specializes in the intersection of machine learning, AI, visual analytics, and translation with the design of healthcare policies and decision support systems. And he was just telling me that he was just with Dr. Kimberly advocating in Washington to more translational science. So we need to get the voices out there how important translational science is. So without further ado, Dr. Bhavnani.
Thank you so much. As I said earlier, I'm hoping that we can explore collaborations at the end of this presentation. This research has been conducted by a large team from UTMB, Texas Southern University, University of Texas Health San Antonio, as well as the University of Pittsburgh. It's funded in part by the NIH AIM-HAD and the UTMB CTSA. None of the authors have any disclosure. So what are non-medical determinants of health? Consider Susan, who has come to the clinic and her doctor recommends chemotherapy twice a week for 3 weeks because they've detected a lump in her breast. However, Susan lives in a rural part of Texas, which takes her more than 2 hours to come to the clinic in Houston. And the concern that she has is, how do I get to the clinic with no car? It turns out that people like Susan often miss their appointments, leading to poorer outcomes than what this excellent care could have provided. This is an example of a non-medical determinant of health, or also referred to as social determinant of health. And I'll be using this term in today's presentation with the short form SDOH. SDOH barriers, like Susan's problem of getting to her weekly appointments, account for between 30 to 55% of health outcomes, according to the World Health Organization. SDOH barriers, such as what Susan has experienced, can significantly impact diagnoses and outcomes. For example, transportation hurdles limit access to timely and quality care, can significantly lower rates of breast cancer screening and impact outcomes like mortality. So this is pretty well known. Lots of research taking one or few of SDOH barriers and associating them with outcomes has been done over the years. However, Americans tend to have multiple co-occurring SDOH barriers. So Susan typically doesn't have just one barrier, but she has multiple of them. And because of that, several models, like the famous Dahlgren and Whitehead model, has repeatedly stated that that these barriers, such as limited access to education, unstable employment, and lack of insurance, tend to frequently co-occur, leading to adverse outcomes such as delayed medical care and depression. And that is our research gap that we're going to try and address today. So the question is, how do SDOH co-occur? Little is known about how SDOH co-occur to form subtypes, their risks, as well as policy implications. Potentially, this research has not been done because it requires access to a wide range of variables. You can't just state one or two that often has been available in EHRs. Fortunately, the All of Us program provides that opportunity. All of Us aims to have data for 1 million or more participants over samples from underrepresented populations Even though they are not recruiting new patients right now, the All of Us program is healthy and active. We have access to a wide range of variables and a ton of data. So the data set provides access to a wide range of these SDOH variables that we will be focusing on today. Our research exploited this availability 2 years ago, and we are still using the same data to go deeper into the research. So our research addressed 3 research questions. The first was, what is the range and response to survey questions related to SDOH in all of us? This had not been done when we started this analysis. Question 2 was, how do these SDOH co-occur? This is the heart of the research, to form subtypes, and what are their risks for adverse health outcomes? Question 3, which is a more recent direction and is still ongoing, related to what are the implications of SDOH subtypes for healthcare policy. That is the ongoing research that we are currently active. So let's get down to the first question. What is the range and response to survey questions related to SDOH in the All of Us program? So the data consisted of all participants in the All of Us data. This was version 6 in 2022. At that time, we had more than 372,000 participants in the All of Us program. We assembled a panel of SDOH experts, and they identified 110 SDOH self-reported variables from 4 surveys. So they each individually looked at 1,113 questions over 4 surveys of the All of Us. And they came then to a consensus that of these questions, 110 related to SDOH, which were then included in our analysis. Then we did all the stuff in the background that data scientists have to do. We negatively coded all the variables to be consistent. We dichotomized all the variables. We excluded invalid responses, abbreviated the questions to shorter labels. This is what takes most of the time, as you know, in data science. Then we categorized the variables by 5 theoretical constructs identified by the CDC Healthy People 2030 program. And then we visualized the valid responses. So all of this is described in detail in our journal article that just got published. So here are the results for the first question. The x-axis here represents number of participants that had valid responses to SDOH questions. These were the 110 questions. The 110 SDOH questions are here. These are our SDOH variables. Each line here represents the number of those valid responses as described earlier. The color represents those 5 CDC theoretical constructs of SDOH, which are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, social and community context. So that's what these results show. So there's good news and bad news in these results. The good news is that these 110 questions had 100% coverage of the CDC theoretical constructs, and this was the breakdown. The bad news was that there was systematic missingness, as you can see in this graph. Systematic missingness in any data is very troubling because you cannot use multiple imputation to fill in the missing data. What's going on here is when you sign up to the All of Us program, you're required to do these 2 surveys. And so there's high response rates here. But a month later, you're asked to do another survey. And so the motivation has dropped, and which further drops with SDOH. We've contacted All of Us about this systematic missingness, and they're trying to address this. But currently, we had to address this problem statistically. Essentially, we cannot use multiple imputation, which assumes random missingness. So that was the results very quickly of question 1, which asked the question, what is the range and response to these surveys in all of us? Question 2, well, because we could not do the multiple imputation, now we were left to look at the cohort with complete data. Here are the 4, this is a Venn diagram that shows response rates for all, for different combinations of these surveys. And as you can see, we're down to 13, almost 13,000, which is only 3.5% of the all of us data. This is still a healthy number, given the 110 variables that we have. So we proceeded with that number. Unfortunately, with this drop came a bias. So for example, in the full data set, white Americans form 54% of the cohort, jumps up to 87%. And the reverse was true with Black or African Americans, started with a healthy number of almost 20% and drops to 3.73%. So this is a bias in the data. And of course, any time we do such analyses, we have to make sure that the data is representative of the target population. So because of this, we had to think very carefully of how to adjust this bias, given that we could not do multiple imputation. So in question 2, we asked the question, how do SDOH co-occur to form subtypes, and what are their risks for adverse health outcomes? The data was, we took those 110 variables and decided to use a method called inverse probability weighting, which essentially upweights all the participants or the demographic variable that is underrepresented. And so that's, I'll be referring to that as an IPW weight that's added to our analysis. The other problem that we identified was that in the survey, the variables were at different levels of granularity. So you had a question like, you have healthcare insurance, and a follow-up question would be, do you have dental insurance? Now, both of those deal with insurance, for our analysis, the variables needed to be independent, and so those clearly were not independent. For that reason, we had to get the expert team back into the room, and they looked at these 110 S2H variables and came to a consensus of whittling them down to 18, what we call S2H factors. So for example, low educational attainment had a whole bunch of these that were grouped together. And this list also included discriminatory experiences in everyday life. This was done intentionally, manually, and in the future, we'll explore how such collapsing of variables can be done automatically. Next, we identified outcomes and covariates. So the 3 outcomes that were selected by the stakeholder team was depression, delayed medical care, and ER visits. And the paper describes how that was extracted from the all of us data. And our covariates were demographics, typically done age, sex, and race. So that's the data for question 2. In terms of the method, we used network analysis. So everyone knows what a network is. Networks consist of nodes and edges. This is an example of a unipartite network where the nodes are of the same type. So Facebook uses this kind of network to do social network analysis to find how groups of nodes form communities, and then they can hit them with ads based on their behaviors. However, in this project, I used a more advanced form of network called a bipartite network. A bipartite network consists of 2 types of nodes, the bipart, patients and characteristics. This is a disease agnostic representation. And essentially, your patients are your rows, your characteristics are your columns, and the edge is the association in the data between the patient and the characteristic. The characteristic can be anything. It can be gene mutations. It can be protein expression. It can be SDOH. In this case, we are using SDOH. Now, a bipartite network has two major advantages for this kind of analysis. The first is the quantitative analysis. In the quantitative analysis, because it's modeled as a bipartite network, which is a computational as well as a visual representation, you can use very powerful machine learning methods like modularity maximization to automatically identify bi-clusters, which is what will be our subtypes. In this representation, once again, the circles are the patients in the All of Us program. The triangles are the SDOH barriers or the factors, and the lines are the associations that are weighted by the IPW to address the bias in the data. And the modularity maximization algorithm automatically identifies the number as well as the boundaries of these subtypes. It gives you a value called modularity, which describes the quality of the clustering. That number of the quality can be used to measure the significance of the modularity, and also can be used to measure the replication in a replication data set. Furthermore, we can measure the risk. So each of these nodes can be colored based on the outcome that you're interested in. So in this case, red represents depression, blue represents no depression, and now you can use standard biostatistical methods like multivariable logistic regression adjusted for demographics to measure the odds ratio of each bicluster compared to each other. So in one representation, you can get the unsupervised learning information as well as the supervised learning information in terms of the outcomes. The second major advantage of the bipartite network representation is for the qualitative analysis to infer the mechanisms, because now you have not only the risk, but also the variables that are co-occurring, and therefore you can use either consensus through qualitative studies to infer the mechanisms that may be causing high depression in this particular cluster versus this, or we are running experiments right now with ChatGPT and comparing the inference that ChatGPT does for such outputs compared to humans. Here are the results from the bipartite network analysis. The training data set was a random half of the data set, which was 6,492 with those 18 SDOH factors. The edge weights were the IPW to address the missing data or the bias caused by the missing data. You can see that the modularity is highly significant, and the co-occurrence of the variables were replicated in the test data set. Here are the results visualized. Each dot here again is the participant from the All of Us. The triangles are the SDOH factors. And in this presentation, I'm going to focus on cluster 1 and cluster 4. The paper describes the rest of the data. So cluster 1 had low educational attainment, low literacy, low income, etc. And the domain experts came to a consensus of naming cluster 1, this was done qualitatively, as socioeconomic barriers. In contrast, cluster 4 was named sociocultural barriers because it contained language barrier, lack of healthcare coverage, mismatched provider characteristics, etc. So these are the two clusters that we will focus on. Next, we measured the risk, the pairwise risk. So using multivariable logistic regression, each pair was compared to each other. The dominant pattern that emerged was that cluster 1 had a significantly higher odds ratio for all 3 outcomes: depression, delayed medical care, and ER visits in the last year when compared to cluster 4. And the interpretation of this uniform pattern was that socioeconomic barriers could be perceived as being relatively unmodifiable, leading to a higher risk for chronic stress and depression. So imagine an American who belongs to this cluster, has some of these socioeconomic barriers. His perception of his upward mobility in the American culture may be problematic for him because he cannot see a way out of his social determinants of health barriers. In contrast, an American in this cluster, for example, an immigrant who is not having a good communication or language problems with their provider, they could take a friend. And so these are some simple interpretations of why cluster 1 had a higher risk for these outcomes compared to cluster 4. So these could be perceived as potentially modifiable. We are getting surprisingly equivalent results from ChatGPT, and we're exploring currently how human experts and ChatGPT could complement each other, but that's the results of another study that we recently presented at the American Medical Informatics Summits this year. The third question was, what are the implications of SDOH subtypes for healthcare policy? This is a relatively new direction of my research. And so I'm going to go a little bit into the background of healthcare policy before discussing our results. So the background is that we are taught to think from a scientific perspective, which is great. But if we want to have impact in the healthcare policy domain, we really need to understand a political perspective, which typically researchers like us don't like to deal with. Which hence the background of what I'm presenting right now is after many discussions with experts at the Baker Institute for Public Policy at Rice University, and the Houston Health Department, just to understand how a researcher like myself can reframe my understanding of how AI results can be translated effectively into healthcare policy. So a typical scientific question that we might ask is, what are the different stages of fetal development? And tons of research done about how a fetus begins from the stage of conception to delivery. But that's not the kind of question that politicians deal with. The policy question is, when is an abortion valid and when is it not? Right? This is a political question. This is a scientific question. And as you can see, this question is very difficult to answer from the scientific answer that we provide the world. Because some people believe that life begins at conception. Other people believe that life begins at the first heartbeat. Yet other people believe that life begins at the first brain activity. So this is what's called the policy paradox, where multiple contradictory answers can all be correct at the same time, hence the paradox. Who's correct? Well, everyone is correct. Well, can everyone be correct? And those are that's the conundrum that policymakers face. Why? Because such questions are based on culture, values, and power, and typically not on science. So policymaking then becomes the process of understanding what people believe in, which is represented by votes, the party affiliation that the legislators that you're targeting belong to. Policymaking is always controversial. Because where you draw the line in these continuous descriptions of the world there's always going to be winners and losers. And so there's always a debate, there's always an argument, there are always fights. But wherever you draw the line in such kinds of decisions, it's fluid because the power structure changes and then now the line shifts. So expect that if a solution is made in one regime, it could change in another regime, and that's very well known in the political arena. And finally, while we as scientists are very attuned to base all our decisions on data, in the political domain, debate and persuasion is the main process of making change. And that's where the narratives come in. So given this background, which I didn't know, which I had to learn in the last year, I proceeded into exploring the question, what are the implications of SDOH subtypes for healthcare policy? So I assembled an expert panel. There were 3 policy experts from a leading public policy institute and think tank. They had expertise in analyzing, designing, and advocating healthcare policies targeted to state and federal agencies. They were physicians who were interested in policymaking. So they had a background in medicine as well as in political science. I had 10 total meetings with them. This was an exploratory study just to understand, essentially from my education, to understand what it would take for us to translate our results into healthcare policy. Each member of the panel studied the evidence of the SDOH subtypes that I've presented to you today. They provided recommendations for the translation into policies, and these were done individually with these 3. And then we had a final meeting to arrive at the group consensus. And so the first expert, who was a political scientist, this was his overall individual independent conclusion. He said that given these results, we could modify current health equity policies that are based on a few socio-demographic factors like race and income. He said, if you go into most of the health equity policies, they are very simplistic. They are based on race, and we know that race has a very weak association with biology, and then you're left with income. And he recommended that we take these SDOH subtypes and start redefining these health equity policies, which are need-based instead of race and income-based. This shift could lead to more efficient and equitable distribution of resources rather than this approximate approach. Expert 2 warned us that we have a very polarized government, and by removing, obviously, race from the equation or being so dominant, you'll get pushback from advocates of race-based policies. So she came with the perspective that in addition to the SDOH subtypes, which the Republicans would love because it doesn't deal with race up front, we needed to be bipartisan in our policy design by identifying which races are significantly higher in specific SDOH subtypes, and then design targeted policies that are culturally sensitive. This is a part of policy design that often we don't think about when we are just thinking about data. Expert 3 had a brilliant idea. She basically said the CMS plans to collect SDOH variables nationwide, which could result in subtypes that vary across geographic regions. So she's saying, don't get hung up with your subtypes from all of us. That's good. It's a good proof of concept, but take real data, identify subtypes at the county level, and now you have policies that are targeted to specific populations per county. We brought them together, and they came to a consensus that we should propose a method, the policy would be the method to automatically identify SDOH subtypes, determine their risk for adverse outcomes, and the racial and ethnic composition of each SDOH subtypes, the visualization of the result could be used to determine how resources will be allocated. This was eye-opening because I had no clue that there were all these other hidden dimensions that were critical for the translational step. Because I always assume, oh, someone will take my results and do something. Well, in 10 years, no one has taken my AI results and done anything with it. So it's time that we start taking a more proactive approach in thinking about how our results can actually be translated into real world settings. So then I went back to understand what these policies were. What are these policies that these experts are referring to? Well, it turns out that they were right on the money, right? So for example, this is a federal health equity policy to address ADRD, and Section 6E in this policy is that Black, Hispanic, and low-income populations face a higher risk for AD and ADRD. This requires that addressing SDOH, entrenched systemic racism and other forms of discrimination be prioritized rather than focusing solely on individual behaviors. Some people believe that policymaking is all about categorizing Americans. That's what it's about. You're drawing lines in the population of who gets what. And this policy is doing exactly that. It's taking Americans, breaking them down into race, and then going into income. And now you're giving money or resources to particular segments of that population. You go into the state health equity policies in Texas, and it's all over the place. The focus is on single SDOH, and our results showing that SDOH do not occur alone. They occur in these clusters based on these models. These SDOH statutes are scattered across chapters because it's been addressed over the years in piecemeal, and they're mostly disease agnostic. And our current research basically states that in certain conditions like cancer, you need disease-specific statutes to address combinations of SDOH. So this was just confirming from the statutes themselves what these policy experts were talking about. And so essentially, what emerged from these discussions is this new concept of what we can call precision healthcare policies. These currently, my definition would be healthcare policies that are geographically, needs, risk, and population specific, leading to more efficient use of resources. So what the third expert in our team, and then a consensus with the whole stakeholder policy team, they're basically saying, use your method to extract county level data, for example, Harris County, where I live. This would enable your analysis to be geographically specific, identify your subtypes automatically using the bipartite network approach. This is the need specific. We estimate the risk and demographic composition all automatically. There's no input. That's one of the powers of this approach, because unlike k-means and hierarchical clustering and all these other clustering, you have to tell it how many clusters you want. You have to tell it, there's no measurement of significance, etc. And we, through our PCORI grant, have automated all of those steps. So you estimate the risk and the demographic composition. This is the risk population specific. These visualizations are then can be analyzed by, for example, the Houston Health Department that we are already collaborating with, and they would make more efficient use of the resources that can be tested through future research. So this is sort of a vision of how AI research could be translated into policies that are more precise in the allocation of resources. So in conclusion, our machine learning results showed good news and bad news for the range and coverage. Essentially, the bad news was there was very large systematic missingness requiring approaches to balance that. And then we identified 4 SDOH subtypes that were interpretable, and they were interpreted as having different degrees of perceived modifiability. The policymaking results were to shift the current health equity policies at the state and the federal level, which are currently based on a few socio-demographic variables, to be more SDOH need-based. And our approach could be a new form of translation, because unlike the traditional translation where you're going from basic science to clinical trials and to the curbside, here we're using AI directly to impact policy change. The Aim Ahead grant that we currently have is taking that all of this further. So I've discussed these two steps today. We are now building a classifier and a prediction model, and all of these are following the principles of human-centered AI, where we have human beings, our stakeholder panels carefully selected from all of these backgrounds to be able to examine and interpret each of the AI models that we are developing. Our code is available on All of Us and Fran. It has been downloaded more than 10,000 times, as I said earlier. We are coming towards the end of our Aim Ahead grant this year. And we are at this stage and we should have a publication soon. So in the future, we're going further in terms of making the connection to policy. So I'm using very simple words here because I want to make sure that our policy analysts and our policy makers understand what we are doing. So I'm basically just saying, our bipartite network is just group the node. How are these nodes grouped? And we've finished that as I described to you. Next, we're going into how are these nodes connected? So we're using causal discovery analysis and generative AI to infer the causal associations. This would help improve the narratives that we describe to our policymakers. Not just these co-occur and we inferred something qualitatively, but do we have quantitative evidence to support that causal, like upstream and downstream SDOH barriers? You lose your job, you can't pay your rent, you have no money for food. So those kinds of causal patterns are what is our next step. And finally, because narratives are so important, we are defining a new form of narrative generation using ChatGPT, where we take representative patients from our data. We know what their variables are. We punch them into ChatGPT and ask ChatGPT to come up with a narrative with different targets. So we may know a Republican, a Democrat, a staff member, and we're automatically generating the same patient's story to these different target audiences. And we will test in the future which of those are effective for the other person comprehending what we're talking about. All of this research is also part of what I'm doing as a presidential leadership scholar. This program empowers Americans from all walks of life to develop civic leadership skills aimed towards social impact. So this is not just academicians. This program picks between 50 and 60 Americans from all walks of life, teachers, engineers, lawyers, as well as professors like myself. We have direct access to civic leaders, including Presidents George Bush, Bill Clinton, and Secretary Clinton. These are the principals, as they are called. I'm honored to be selected as one of them. This is the cohort for this year. I've already had short discussions on what I've showed you today on AI and policy with both these presidents, as well as Secretary Hillary Clinton, and her staff has invited me to send this research to her group because they're very interested in health equity policies using AI. This is my project to design and advocate for a policy that addresses health inequities based on SDOH subtypes identified through AI and machine learning methods. Thanks to Dr. Kimberly for giving me the opportunity to advocate for translational science last week. I was the lead in two meetings at the offices of John Hornan and Ted Cruz on Capitol Hill. We didn't meet them personally, but we met their staff. This is Lucy Flowers. She's very interested in AI as well as healthcare, and I'm building a personal relationship with her as a trusted expert of AI whenever she has questions related to either translational science or AI in healthcare. This is how you do advocacy moving forward. And I did the same thing for AMIA a couple of weeks before that. So our journey has just begun. This is our publication that recently came out, and that's me in the cold air of Washington, D.C. last week. Thank you very much. I'm ready for questions.
Yeah, thanks for the great presentation. And, you know, we're so used to being in the trenches and the numbers, and it's nice to see how things can take on a bigger role at the advocacy and more leadership, government policy level. Feel free to either unmute yourself. We don't have a, you know, I think a lot of us know each other, or also you can put your questions in the chat.
Yes, Jim.
So what are your thoughts on how we can improve the quality of these data, the accuracy? We depend on electronic health records for these data to a great extent, and they're not, you know, they're not gathered for this purpose. We don't, you know, when I was in training, we did have a social history section of our admission note, but it was, I mean, the questions were, do you smoke? Do you use drugs? How much alcohol do you drink? You're sexually active. That was kind of it. On social,
Yeah.
That's what we called social determinants. And while a good history would include things like, you know, what kind of work do you do? How long did you do it? You know, things like that. We certainly didn't ask questions about, well, are you living in an area, high crime area? Are you, you know, is your family impoverished because of past systematic or interpersonal racism? Or, you know what I mean? So how do we get at some of these data instead of using sort of, you know, census tract stuff and to try to infer it?
Yeah, that's more a cultural issue, right? Because I think CMS has, you know, before the shift in political power, CMS was very serious about collecting these data at the county level. And you know, there are some indications that it would continue in the future, but many hospitals are beginning that process essentially through surveys. So the social workers have begun to address that issue. There are many instruments available, validated survey instruments that are available right now. Through the CDC website, you can download. I think there are 3 instruments that you can use. You pick the one that's most appropriate to your population and just start collecting those data. But there's no easy answer to that because that's more a policy issue at your hospital level. Does that answer your question?
Yeah.
Elizabeth.
Yeah, great talk. Really wonderful work. At AHA, American Heart Association, we've been working on trying to make sure that definitions of different social determinants of health, interpersonal, individual, you know, community are harmonized across the different frameworks. The ultimate goal was that when health systems start collecting this, whether they're embedding it in the EMR, or some other way, that they're able to use similar definitions so that we can track things over time, but also across different populations. And I'm wondering if you all have thought about that. My other question is, we also did a series of things projecting in the future to 2050 in terms of of different risk factors and cost and burden. Unfortunately, I didn't decide, but I'm the senior author on one that it will look at social determinants of health and projection. But I think with your models, there's a real opportunity to, tell policymakers, okay, if we are able to, modify or intervene in something in this way, or provide some intervention in a community level, then we can shift, the needle on certain things like heart disease or blood pressure. And that to me is a really compelling argument. And I'm sure you've probably thought about it, but yeah, those are my questions and comments of what you all are doing in those areas.
Yeah, I've forgotten the first question already, but the second question, absolutely. Our Aim Ahead grant takes this whole paradigm and applies it to cancer. And so we are looking into cancer-specific statutes in Texas related to SDOH. There are very interesting similarities and differences when you compare cancer SDOH subtypes compared to any condition, which was what I discussed today. So for example, we have, this is the model that I showed you today. And then the cancer, this is any of 92 cancers. And you can see interesting movements of certain of these SDOH factors into cluster 3, and that begins to explain the complexity of cancer versus any condition. So it's just an example of how we are looking. This initial model was disease agnostic, but we're getting down into specific diseases, of course, dependent on the data, because as you get finer and finer, you lose more and more data in all of us. So your question is very good. There could be policies that are disease specific or condition specific that need to be addressed. We have also proposed this to CPRIT, which is a Texas specific grant mechanism. What was your other question, Elizabeth? I'm sorry.
The first one related to harmonization of different terms. Yesterday, I'll give you an example. I just gave a talk of social determinants of health for Wisconsin for grand rounds, and I used peripheral arterial disease as a framework. And really, it was very difficult to compare different studies because they all use different cut points and different measurements for, income, education, not even like neighborhood context or any of the other things that we're interested in. So harmonization of things.
A good place to start is back to all of us. They've done all of this heavy lifting. They have these validated surveys. They spent several years coming up with those survey instruments. The latest survey instrument is just focused on SDOH, but as Jim indicated earlier, they are things related to zip code. It's not just one survey. The SDOH is scattered even in SNOMED codes, which physicians currently do not use. That's another area that if physicians started using the SNOMED codes, which exist for SDOH, but they're not paid to do it. And so it's often overlooked, which is why we come back to the surveys. So Elizabeth, if you don't even have to be part of the All of Us program and go through that training. You can just download their instruments and trace back the references on which those instruments were designed. I hope that's a good starting point.
Yeah, I guess that my point was that, the national societies have a role for advocating for the standardization. And that's why AHA, put out a statement on the importance of harmonizing and using similar definitions across, certainly we used a specific disease state, cardiovascular disease. So, yeah.
Yeah. And, I believe the All of Us surveys are very carefully done. This was done when they had money, right? And so it's solid science. And I think those surveys were excellent. It's just, the more extensive and detailed your surveys are, there's lower motivation to complete them, right? I mean, how many of us respond to every survey invitation that we have? And so All of Us now is actually taking puts a laptop in a van and they drive up to the participants who have shared their data and request them to do the survey on site. So, they may not have a laptop or the time to do it, right? And so the data integrity, I mean, it comes down to the same basic things, getting good data. But All of Us has been amazing, absolutely amazing. Our experience as data scientists has been fantastic. And I keep telling that to everyone who hears these talks, from all my experiences over the last 15 years of doing such analyses, All of Us has really, really overcome the IRB hurdles. We didn't have to do any IRB at all. It was a university-wide IRB, and they've solved the legal issues. They've provided, the only thing is it's a federated system, so we have to put our code. So there's a fair amount of programming. You can't just, walk into All of Us and start doing data analysis. You've really got to have a strong programming team to do this kind of analysis. Well, we had all of that ready to go. And we had our AI models ready to go. They were already on CRAN, on public repositories. So the moment the grant came out, the moment the data came out, we just hit really hard, extracted these 110, and we were ready to go. And so that's, a lot of things had to come together for this project to happen. And I guess we were just lucky. Bob.
So first of all, thanks very much, Suresh, for a great presentation. I think it's been stimulating for all of us. All of the participants in your seminar this morning, in addition to All of Us, the national program. But did I hear correctly that the clustering that you're illustrating on this slide may vary a little bit, depending upon if you're thinking of persons with clinical conditions, they may vary according to the clinical disease.
Yes.
Illustrated cancer, and that the clusters might also vary according to the location in the country. And I ask that because as I'm looking at this cluster, if I were seeing maybe thinking about some of the patients that Liz sees, could I map outcome for condition X, the likelihood of a good or a less good outcome according into these clusters? And I think then what I would need is I would need the geographic specific as well as the diagnosis specific clustering upon which would be layered outcome. Is that a correct understanding?
Absolutely. Very good. Let me get back to this slide, right?
Okay.
So this is our future vision of precision healthcare policies. CMS has collected the data at the county level, all the SUH variables. We extract those data. So the Houston Health Department would download those data. They know that those data exist. So that's where you address the geographically specific data. You use the bipartite network, and we actually don't care. I mean, you could use whatever clustering method you prefer, but this is, a powerful approach because it's visual also. So then when we add the variables here with these, with the patient records in Harris County, you have a geographically specific clustering, right? So that's what's going on here. Then we measure the risk because, from historical data, we may know the risk of those patients in terms of heart disease or whatever, right? So now you have risk and population-specific information, and then you have the visualization, which is then pondered upon. These people are already doing it. It's not like it's automatic. They get money from the federal government, and they decide through these meetings who gets what, right? They in Harris County may decide that you have to be 66 years, 65, whatever. So these discussions are happening in these health departments based on their local context, right? And I'm basically saying I'm going to fit into that pipeline by introducing this method.
And part of the reason I was asking is within our CTSA, one of our Element E projects is actually using social determinants of health as perhaps even the predominant. So it's a test, but the mechanism by which follow-up outpatient care after discharge from hospital is allocated based on the presumption that the resources available are intrinsically limited.
Yeah.
And so we need to use them as efficiently as possible. So it's coming
Correct.
from it's coming from the individual perspective. The idea, though, I think is the same. How can we best allocate what resources we have?
Absolutely.
And then I guess what you would say, this approach could be used by any healthcare system with the clusters adjusted for your local environment.
Yes.
Got it.
Perfect. That is the big eye-opener thing that happened in this qualitative study. This woman, who's a physician here in Texas, she said, don't go with your national level subtypes. You have a major opportunity here where your method could be the policy itself. I repeat that. I mean, I didn't know what she was talking about. She said, you're thinking about policies as something separate. She's saying the AI method could be the policy. And I was going, oh my God, I didn't even get that earlier, And then I said, oh my God, this is a new form of translation. You've never spoken about translation in that way. So AI becomes the vehicle of translation. It's not some clinical trial or something else that people are doing. We can do it. We informaticians can do it. That was the aha moment for me.
Well, it obviously is a combination of AI, which I view as a tool to better understand the data that are gathered.
Correct.
Through the EMR and likely other sources too.
Yes.
But your point's well taken. This can be used could be policy at a county level, or it could be operations at an individual level. But the idea of being data-driven in the most effective way of distributing resources, I think is essential to both perspectives.
Correct.
Really
and we remove the word fairness and all of that, given all of the stuff, right? And we just replace it with, and my dean says by replacing it, you're really not changing your values. We're still fair. We're still giving resources in a more precise way.
Yep.
Right? We're not talking about race and income. We're talking about needs.
Right.
And then over time, those clusters could change.
Sure.
So, you're embracing time, you're embracing space, and all of this has become possible because your AI is the mode of translation here.
Super.
So,
thank you.
Just a quick comment. Unfortunately, Jim Semino had to leave for another meeting. Matt, you have a comment? I think you're still on the call.
Yeah.
Not necessarily a comment, but needs elaboration. It's just some of the things that are the most consistently documented and in the past have been considered in the realm of social determinants are not even social determinants at all. And those are the only things really that are documented with any consistency in clinical practice.
Yeah, things, yeah, there's this kind of blurry boundary between social determinants of health and social history, which, you know, there is some overlap, but a lot of times social history is things like, you know, risky behavior and, you know, alcohol and tobacco and things like that. But those are not considered social determinants of health at all from your definitions. So sometimes when we're collecting data that you just have to know to have those distinctions.
Yeah, so, you know, in the appendix of our paper is the list of all the 110 that the three SDOH experts selected. So, you know, that's a very good place to start the conversation. We had a very broad umbrella definition of SDOH. I mean, there are all these terms, upstream, downstream, what is social, and, you know, all of the stuff. And we said, okay, fine, we'll just throw everything together, right? That's the approach we took, but it's publicly inspectable in the appendix of that paper that was published in February, and which Hillary Clinton will read soon, because it may be of interest to her.
It may be also worth noting that there are some folks out there, large national networks, like PCORI in particular, where we are currently mapping social determinants related things, and some of those things are included in the list. I mean, they are still being propagated out there as part of the social determinants landscape.
Excellent.
And
excellent. Yeah, we took a very expansive view, and I mean, I'm not out there collecting data, right? I'm the AI person, and so we were amazingly lucky to get this pot of variables. It was fantastic. And so, you know, health equity experts who are reading the paper, you know, see value in it. So I'm glad it's, you know, I've given 3 keynote addresses on what you heard today, even in Switzerland and Mexico. So there's a lot of interest in SDOH, but this expansive view of SDOH, not just zip code and a few others. So thank you so much for your attention. I hope to hear back from you through email, and we'll talk soon.
Yeah, thanks, everybody. You know, we'll have a good weekend, and we'll see you next fall. Bye-bye.
Bye-bye. Thanks. Thanks, Amy.
Thank you so much.